Thank you. So I'm going to talk about IIH and a new stent for sinus stenting and the clinical trial that is involved in its development. So I have a huge conflict of interest. So Julia, the best way to have stocks in a company is to fund your own company. And then you are giving the stock to yourself. So I am an INR having performed a venous sinus stenting for IIH patients. I wanted a stent that was done specifically for this application because I thought that the arterial stent did not fit the requirement for sinus stenting. So despite my conflict of interest, I will try to present first kind of a reminder of what is IIH, what is severe IIH, what are the current surgical treatments, and then I'll talk to you about the stent and the design of this clinical trial. And I'm completely biased. I really think that venous sinus stenting is the solution for this for IIH, and that it should be the first procedure to do for every patient who fails medical treatment. So IIH is it's a rare disease, but it's increasing with the obesity epidemic. And now that it looks like in the US, it's like a snowballing effect where there are enough IIH diagnosed out there so that many cases that were not diagnosed before are also because there are enough physicians thinking about it. So of course, we are diagnosing cases with papilledema and also IIH cases without papilledema that are much more frequent than we think. So symptoms are kind of almost always an association of headaches, visual symptoms, and tinnitus. And you have also to realize that for many of these patients, their quality of life is really hell because of chronic fatigue, cognitive impairment, loss of libido, and depression, anxiety. And many of these patients are overweight female. And, you know, maybe there is some prejudice against this population. And when they complain of functional symptoms, like constant nausea, fatigue, etc., their symptoms are dismissed very unfairly, where they have IIH. What will make the diagnosis, though, is when there is a pulsatile tinnitus, you know, and visual symptoms. So in many cases, more than 50%, IIH is a chronic condition with chronic medical treatment, disability, and loss of productivity in young people. Those are young women in reproductive age. And the cost is very expensive to take care of this population. So the visual signs are really the most classical one, and they will alert you to the diagnosis. And the neuro-ophthalmologist will examine, will see the papilledema, then you have the diagnosis. You have to understand also that in many cases of IIH, of severe IIH, those visual field defects evolve and become more and more severe. And the visual acuity also decreases, and this leads to blindness. In the old time, untreated IIH was making people blind. So that's a vision on the blind spot and depression on the visual field. So don't worry, I will not read all that. Just to more and more now we are diagnosis IIH. Let me see. Do I have a yes IIH without papilledema, and that's kind of an issue, you know, because this disease was first diagnosed by neuro-ophthalmologists. That were the one who taught us what this disease is. And now we are telling them, you know, they are IIH without papilledema, so you cannot see anything on, and so they are a little bit dubious, you know, about does it really exist? Well, it does exist, and it's more frequent than we think. So venous sinus stenosis, it's almost constant in every IIH patient with severe IIH. Patients will have a significant sinus stenosis. It has to be bilateral. It's rare. So sometimes when there is here, for example, where you have a very asymmetrical torcular, where the superior sector sinus here is going left, here sinus is going right. So an isolated stenosis could become symptomatic, but it's actually really rare. And in most cases, the stenosis are bilateral on the transverse sigmoid sinuses. And so it's a little bit difficult to understand how the IIH itself can be at the origin of a stenosis, but the stenosis is also at the origin of the IIH, or at least of symptoms worsening, okay? So it's kind of a vicious circle that you can break, that you should break. So what comes first? You know, is it the stenosis or the increased ICP? And it's both. And 2007, Rohr published that doing an MR before and after lumbar puncture, you know, after the lumbar puncture, the MR was showing less stenosis. Okay, so it was compliant, it was a reversible stenosis that where the sinus expanded after lumbar puncture, decreasing the ICP. On the other hand, there are also cases where the venous sinus stenosis will persist after normalization of CSF pressure. And the way to understand this is that there are really two types of stenosis, and they can be present in the same patients. There are the intrinsic stenosis, okay, and most often it's a hypertrophy of the granulation, okay. So those ones, they are not reversible. They are always there. And they are much more frequent in patients with IIH, okay. It's very rare to have a patient with no IIH and with very prominent bilateral. So IIH itself as a disease does something to this, does something towards granulation so that they become hypertrophied and then they narrow the sinus. So that's one type. And the second type is the extrinsic stenosis, where it's kind of a tubular collapse of the sinus. And this one happens at the sigmoid transverse junction. This one happens at the transverse sinus only. So the vicious circle, you know, what comes first? Well, it doesn't matter if you break it. And you can break it by various treatments. Then here they are. So first, I've had this criticism several times, is people telling us, you stent the sinus, but you don't treat the disease. You don't treat the ethiopathology of a disease. Well, actually, none of the treatment that we have addresses the ethiopathology of the disease. They are all aimed at treating the consequences of the disease, so medical treatment, the acetazolamide, the Diamox, will reduce CSF secretion. That's how it will improve the ICP, okay? But there is no hypersecretion of CSF in IIH, okay? So it doesn't address the physiopathology. Same thing for the topiramate, which is very effective against headaches, and so it is a good treatment because it's anorexigenic, so so people can lose weight with this drug, and it reduces CSF secretion. Same thing for the lumbar puncture, CSF shunt, they subtract CSF, and it's also a symptomatic treatment. Optic nerve sheath fenestration. I don't know if you all know what this is. It consists of going on the side and doing a little slicing the sheath of the optic nerve. It's a little bit tricky to do. So not many neuroophthalmologists know how to do this procedure, and it has a significant number of local complications. Finally, when we do venous sinus stenting, we actually we are the only technique that provides an etiologic treatment, at least for the intrinsic stenosis. Just something, if you have any questions, do not hesitate to interrupt, please. Where is? Oh, bariatric surgery, yes. So it actually works very well. It works very well because because they lose weight, and their symptoms improve almost always. The only problem with bariatric surgery is that you have to make sure that the patient can wait the 3 to 6 months that are necessary, so that visual symptoms are not too intense, so that they can wait. So venous sinus stenting, so that's a nice 3D rendering, and this is what we do now. I mean, that's at Cornell, we place 2 stents. So one stent from the mid-sigmoid to the mid-transverse, and one from the torcular to the transverse, to cover both sinuses with 7 to 8 centimeter of length of stent, to avoid some recurrences. And that's the papilledema before, after. You can see how it improves. The improvement is really very fast. It starts at 2 weeks on the exam. So I used the data, the experience that we had at Cornell with arterial stents, mostly with a Cordis stents, to think about what new stents we needed. So I'm just going to present to you very briefly the experience that we had at Cornell with using arterial stents. And first, our only adverse events were 2 retroperitoneal hematoma. Okay, so we had no neurological complications, and that's why now, especially in these obese patients, it's very interesting to go radial when you need an arterial access, and even for the venous access, you can go through the basilic vein, so you don't have to go femoral at all. When we do first stent, yes, aspirin and Plavix, both, double antiplatelet.
How long? Double. How long?
So at Cornell, we do 1 month of both and 6 months of one, 6 months of aspirin. But I know that there are many other protocols. Some people will give for 1 year, some people will stop at 3 months.
In the another vein is more time?
Yes, usually it's more time, 3 months. For example, oral anticoagulation for 3 months, or you may have low molecular weight 3 months, followed by antiplatelet aspirin or Plavix. Never. Venous, deep venous.
Pierre, as you know, that for those patients with IIH, some of them may get better after shunting, even you may see that the so-called stenosis of the sinuses may disappear, right? But I do agree that we may treat them with venous stenting. But do you do manometry before deciding? Do you look for a pressure gradient between, for example, supersagittal sinus to sigmoid sinus, or how do you define when to do it?
So, like most people, we use we use an 8 millimeter gradient threshold. 8. Why 8? I don't know why. I think the first guy who published, I think it comes from the experience of the Australian who used 8.
How, what?
And
I'm sorry, is there a certain number, or you use a percentage? Let's say there is a 20% gradient between the proximal and distal.
no, it is not a relative number. It's not a percentage. It's an absolute number. Problem is that those obese patients, they can have a very high central venous pressure. So if you start with a central venous pressure at 20, for example, which is not impossible in those patients, and then you go up by about 1 millimeter mercury every sinus. Okay, so sigmoid sinus you go up, and transverse one more, and superior sagittal sinus one more. So you need a gradient, not an absolute number. With a gradient of 8, you have a reasonable chance that resolving this gradient, from 8 to 0, will be enough to improve the symptoms. However, in patients with high central venous pressure at baseline, you will not cure these patients, but you need this gradient. Now, I know Hopkins is one of our sites for our clinical study, and when they do this procedure, they use a gradient of 4 instead of 8. And the reason for that, it's because they say that if they were going to use 8, they will not enroll many patients. But that's because they do the lumbar puncture with a lot of CSF subtraction just before. So of course, if you do CSF subtraction before doing the stenting procedure, you are not going to find a huge gradient. So so what was interesting is that the opening pressure on the lumbar puncture was significantly reduced, pre-stent, post-stent. So the criteria that we use for patient recruitment, it's everyone uses this, is 25. 25 centimeter of water on the opening pressure. If it's above 25, you can reasonably say that the patient has IIH. That's because the patient are obese. If you have a very thin patients, and some IIH in some male patients are thin, and in this case, you can use 20. But overall, it's nice to use 25. And so after stenting, the decrease of the gradient is real in extrinsic stenosis as well as in intrinsic stenosis. So the procedure works on both. So it's interesting because in intrinsic stenosis, we treated the disease itself, while in extrinsic stenosis, we treated only the consequence of the sinus collapse due to IIH. So we treated 2 different diseases, but the important was to break the vicious circle, and the results are as good in the two diseases. They are as good in terms of short-term efficacy, but in terms of recurrence, if it is an extrinsic stenosis, you have to expect a rate of recurrence that will be higher.
More strong.
So, no, they will not develop a recurrence at the level of a stent. They will develop a recurrence above it.
In your cases, do you have an enlargement of the ventricles or not?
No, so in IIH, the ventricles are very small. Yeah, and
In all your cases.
in every one of our cases, yes, yeah.
It's not criteria. It's not criteria. You go up with it, but it usually is.
So in our experience at Cornell, we could reduce the dose of Diamox, but in many cases we could not completely stop the Diamox. So it's really with venous sinus stenting, we are not curing IIH. We are just making it, improving it clinically. And in terms of visual outcome, same thing. It's very effective against the papilledema. Papilledema decreases very fast and very well. The Friesen grade normalized very fast. Visual field, well, it depends a little bit what you start with and what else, but it also works. So if we go to, and all the visual symptoms, those ones, they recover very well, transient visual obscuration, diplopia, etc. Headaches improve also. Maybe it's not as clear because headaches can be multifactorial in those patients. Now, if we see the patient that failed, so it's about a little more than 10%. If you work at a 1-year follow-up, if you have a little more follow-up, you arrive with a rate of recurrence that at least 15%, and it could be even more. But what is interesting is that the new stenosis were not within the stent; they were above the stents, and then you can decide: do you put another stent? Do you dare to stent the superior sagittal sinus, or do you choose to do a shunt?
The morphology of the stenosis in intrinsic stenosis, what is the new morphological change?
Sorry, I don't have the. So let me show you an example. No, I don't have an example here. So you, for example, you will stand the junction straight transverse, and then you will have a stenosis appearing at the transverse. Then you put a second stent into the transverse, and then you have a new stenosis appearing proximal, appearing at the superior. So when you are chasing the stenosis like this, maybe it's better to place a shunt, But now many of our colleagues in the US, they will treat the inferior half of the superior sagittal sinus in case of recurrence. Not first intention, but in case of recurrence. So when we submitted to the FDA, we submit our application to the stent to the FDA, we had to do a review. The FDA asked us to do a review of the surgical treatments in IIH. So it's a study that's going to be published soon. And I can send you the slides if you are interested, but I don't want to read everything. I just want to say that, look, now we are at 825 cases of sinus stenting that has been published, okay? So that's not a lot, but we are really starting to gain experience, okay? The problem with the follow-up is that many of those cases, you don't know what the follow-up is. So it's very difficult to analyze the recurrence rate. But we know that at this short term, it works. It improves visual field. It improves the visual acuity in the cases where it was decreased, of course. It improves headache in a significant number of cases too, 7 to 72%. So as good as shunt. And it improves papilledema also. So the two old treatment, the optic nerve sheath fenestration, those were reserved when the eye was involved because it's very effective at reducing pressure into the eye. And the shunt was reserved for patients who have visual symptoms, of course, but also who have a lot of headaches, okay? What is good with stent is that it looks like it it works on both.
But the problem of shunt is that the transmural pressure in the brain is worsening because you decrease the external pressure to okay. If you decrease the external pressure to the vasculature of the brain, you increase the transmural pressure. So symptoms on long time worsen. Your approach is absolutely better because you decrease the pressure in the vasculature, so your transmural pressure is improved, and your results are more stable.
I think so, but shunt works. The problem with shunt is that you have to redo them because the ventricles are collapsed, and so shunts have a half time, that is short. But patients are very improved immediately by shunt. I think the problem of shunt is more long term. So within this review, what we did is that we analyzed the 12-month failure rate, and 12-month failure rate with shunt is almost 40%. Okay, it is there, and this is and the 12-month failure rate of venous and stenting was 13%. The only problem is that I am sure of the 39% here on the left. I am not as sure of the 13% because some of these studies have short follow-up, and so this is less reliable. Maybe this rate of restenosis is more than 13. We'll see. So it looks like what I've told you, so far is that the evidence is overwhelmingly in favor of stenting, okay? Except that it's not rosy, because there is a problem with stenting, is that there has been some death with stenting and some bad hemorrhages, okay? When you do an optic nerve sheath fenestration, the ophthalmologist does this and he has a complication. Complication will be a nerve pulse, will be a hemorrhage into the eye, okay? The patient is not going to die, okay? If you do a shunt, shunts are difficult to place into those slit ventricles. So it's also delicate, but patient is not going to die. I mean, it's completely exceptional. When we are at 1.5% of death in the reported case with sinus stenting, okay? Thank you. The police is coming to have me talk in front of a microphone. So we have really to solve this problem of neurological of severe complications. And this percentage of 1.5% is in the cases that have been reported. And I know because I interviewed many people in the US, I know that there are many severe complications that are not reported, that are never published. And I'll talk a little bit later. Yes, you have a question?
So if I understand you correctly, and maybe my understanding is of idiopathic hypertension is wrong, but it's a self-limiting disease. So given, I've treated about 15, 20 patients so far with Diamox, and a couple of years later I've withdrawn treatment and they've done well. So the question really is, it's cerebral edema basically that is happening. I mean, and which is causing the slit-like ventricles. And also the stenosis is a consequence probably of the cerebral edema. That's why when you reduce the ventricular pressure, your sinuses sort of, as you said, become more obvious. So in all cases, what you're talking about is really, if they are not responding to medical treatment, then you would do the shunting. Right?
So yes, in this presentation, and I said this from the beginning, I'm talking only about the severe cases that are resistant to medical treatment. I'm not contesting the fact that 80% of patients will do well on Diamox. Okay. They will do well for you because they will not develop papilledema, they will not lose their vision, and maybe they will not complain so much because you don't have anything much to offer to them. But they are miserable on Diamox. And I think this is a more general problem, the question that you're asking. So I'm going to finish my presentation and we'll talk about etiology and all this at the end. So from all the cases that we did, I thought that there was an unmet medical need, a stent specifically designed for this application. So first, now to prevent stent adjacent stenosis, we currently use 2 stents, which is not a big deal. You know, you just place 2 Cordis stents or 2 stents from the torcular to the mid-transverse sinus. You are obliged to place 2 stents because there is no stent that is long enough, you know, that is 7 centimeters long to cover the 2 sinuses at the same time. So that's why we need to place 2 stents. Problem is that when you place 2 stents, where do they cover these stents? They cover where l'abbe goes. So that's a problem. So placing 2 stents is yes, okay, but the anatomy is not very in favor of that. So solution, make a longer stent that you can deliver. Then when you use stiff arterial stents, you will compress the wall of the sinus, you know, where the veins go. When the veins go, they don't go direct. They have a little course into the sinus. And if you compress, if too much pressure, then you will occlude those veins. Actually, what is interesting is that those stent of the cases of venous occlusion and hemorrhage are really rare. Described in the literature, it's really rare, but you know, it may happen. So I thought that we had to use a stent with less radial force. Then a problem of cerebral hemorrhages. Certainly most cerebral hemorrhages, especially when they arrive at a distance where you place the stent, they are due to the stiff wire. The 35 wire that you put, you know, so the 35 wire into the sinus is not going to be an issue. But if this wire goes into a cortical vein, then that's the problem. So can we make a system so that we don't have to use a 35 wire into the brain at all, and we can work with 14? So that's a case of restenosis. Okay, so that's what you were asking. So we place a stent, the patient improves, and then 4 months after, symptoms appear again. You have severe and stent stenosis, and we place a second stent. And in this patient, it was good enough. Okay, but sometimes you will have a patient improving there. 6 months after, you have a new stenosis here.
L'abbe, look that.
Yeah, l'abbe was okay here.
No, it's okay, but
the
size is.
It's exactly there. So that's a case where l'abbe slow down. 3 stent, post stent, you know, with you see l'abbe compared to the other vein. So we place this patient on heparin, and she post stent. Place this patient on heparin, she did well, but it is a concern. So this is the stent that we made. So it's a 7 centimeter long. It has two zone, a larger zone here. Oops. So okay, that's an example here. Sorry, I'm going to go there. So it has a large zone here that goes into the sigmoid sinus, and a smaller diameter zone here that arrives at the torcular. And the stent has 2 zones of stiffness, because this part from here to there that you are going to deploy into the sigmoid transverse junction. This is where the arachnoid granulation that you want to compress against the wall are. So you need a lot of stiffness here. While the proximal part, proximal, if you consider the flow, the proximal part that is close to the torcular, there are no granulations there. You want something soft because you don't need a lot of strength to counterbalance the extrinsic stenosis. So this is what we
What
did.
is the main difference with the silver sample?
It's actually close to the silver, except that it's longer, it's easier to catheterize, and the stiffer part of the stent is stiffer than the silver. The softer part is softer than the silver, but the differences are not huge. The silver is a good choice for, except you have to put two, but it's a good choice.
But it does not conform the shape of the sinus to silver stent. This is the problem.
So the problem is that sinus is triangular, and you cannot make a triangular stent. But at least this stent is open cell design, and the open cell design conforms a little bit better than a braided design, or a closed cell. So that anyway. So initially we thought that we could work with a one size fits all, and it doesn't work that way. We need several
What is
sizes.
the maximum diameter?
So we have 3 stents now. So this was the first model.
Yes.
So proximal is 9 at the torcular, and distal at the sigmoid is 10. But now we have a 6-8 and a 7-8. I mean, we will have.
Proximal.
The 9 is the distal and then 10 is the proximal.
So if you consider, if you consider the catheter, if you think catheter, if you think the device, distal is the one that is the farther from you. But if you consider blood flow, and it's nice when you stent a vein to think blood flow, then you reverse proximal and distal. So it's just a question of convention.
Is close to the heart or to the brain? 9 millimeter.
9 millimeter is 9 millimeter is at the torcular, proximal to flow, distal to the heart, proximal to flow. So yeah, that's the position of the stent. So this will be proximal, blood flow is like this, and this will be distal. Here you have the granulation, and so you need something large and stiff. And here you can have extrinsic stenosis, but it's always soft, no granulation. So you want something a little softer and a little bit smaller.
Here, I suggest you now proximal distal. You talk with friends in amont or in aval.
That's true. Yes, it's better.
It's better.
So our study, the FDA asked us to treat 39 patients in up to 10 US sites. We'll treat patients with moderate or severe IIH that with symptoms are resistant or intolerant to medical therapy, with 2 subgroups, patients with severe headaches or patients with significant visual field loss. Primary safety endpoint is the major adverse event at 12 months. And the benefit endpoints are a composite at 12 months of absence of significant venous stenosis anywhere in the brain. So not only in the stent, but also above the stent. And clinically relevant improvement in the main clinical outcome. And the FDA did not want us to treat papilledema, they want us to treat visual field, which is much more difficult to analyze. So, so that's why we had this endpoint. And then in secondary endpoint, we have a CSF opening pressure, a ton of ophthalmology endpoints, tinnitus, and what I think is going to be very important is quality of life assessments. So that's an example. That's a case that was done at Buffalo, and by Adnan and the team there. So, I mean, it's, okay. So you see this patient had a gradient of 11. That's a good gradient, 11, 15. It's a good gradient because you know that if you suppress this gradient, you know, it's going to work. Okay, so catheter. So you put the microcatheter, you do the exchange. And that's a 14 wire, okay? I recommend to place a J so that you cannot go into a cortical vein, you know, without no. Then look how the stent is going up. So
Is it transfemoral?
it's a transvenous. It's 7.
What is the size?
It's transfemoral.
So we have a 6 French guide here, and the stent is there.
You prefer crossing with the temporal to the
No, no. This is kind of an oblique view, so that's why.
What is the size of the delivery, the catheter?
The microcatheter, it goes through a 6 French guide catheter. So it's a 0.07, 0.60, 68, I think. So every catheter which has inner diameter of more than 0.71 will be okay. So that's the initial stent there that we used. And this stent is probably too large for most patients. Well, actually, I probably not. I don't know. So,
Do you recommend for the
yes. So let me go there. So we have enrolled 19 patients, implanted 18, and the procedure was very easy in every case. And initially, we had only the 9-10 stent, except that we had just done the follow-up. We have done the follow-up of the first 2 patients, 1 year follow-up of the first 2 patients, and we had 2 recurrent stenosis above the stent. So we have followed 3 more patients, and those 3 are doing very well. So, but we have 2 restenosis out of the first 5 patients. So I don't know if it's a statistical blip, you know, but it's high, you know, 2 out of 5 is 40%, but you cannot say much about 5 patients. So, but certainly the thing is that in the US, at least, the people who are putting those stents, who have a lot of experience, have observed that they have less restenosis when they use small stents. So that's why we have added two stents to our original one, to our 9-10, so 9 proximal, 10 distal. Now we have a 7-8 and we have a 6-8, because this is what the physicians are using now. So our trial, we have placed enrollment on hold while we are building those 2 sizes, and we should restart the trial in April, I hope, with a range of sizes. And using commercial stents now, you know, using, I know at Cornell we use Cordis, but I know in France, Emmanuel Houdard will use the wall stent. We'll use 7 millimeter. So if the 2 sinuses are codominant, you will use 6 millimeter. And if 1 sinus is very dominant, we will place a 7. In the old time, we were placing 9, even 10 millimeter. You know, we are placing 10 millimeter into the transverse sinus, way too big. And then we went to 9, 8, and now we're at 7 and even 6.
But it wasn't a function of the diameter that you measure on the cone beam CT angiography?
So it's the problem.
I hate to leave any space between the stent and the sinus wall.
So, gosh, I did not know I did not know you had so many questions, because I would have prepared something. It's not a diameter. When you measure the sinus, it is not a diameter. You measure the largest side of a triangle, and it's not an equilateral triangle. it is a triangle which one side is usually significantly larger than the other one. Okay, so if you are using a carotid stent, okay? You stop me in private.
Yes. No, in private, no, here.
Oh, here.
At the
Okay.
time he posts the presentation.
Yes,
Okay.
yes. I don't. So, if you treat a carotid with a carotid stent, you measure the carotid at say 6 millimeter, then you place a 7 millimeter stent. Okay? Yeah, we agree. If you measure a sinus at 8 millimeter, say, okay, it means that imagine a triangle which one side is 8, then the second maybe 5 or 6, and the third is 4. Okay, 8 plus 4 plus 5 equal 17. Okay, so it's 17 millimeter. The perimeter is 17. 17 millimeter perimeter, it's a 6 millimeter stent, because 6 multiplied by pi multiplied by 3.14 equals 17. So it means that when you measure a transverse sinus at 8 millimeter, you should not place a 9 millimeter stent, you should place a 6 millimeter stent inside, because it's a triangle. So this, but it's so, I mean, it took me some time to understand that. And it took us 2 years at Cornell and at Hopkins. It took us two years to understand that you need to go down in size. We are not used to do that. Yes, you are afraid of thrombosis. And then there is also something, when you treat a carotid, okay, and after a severe stenosis, you will have a collapse, okay? So what happens into the veins? It's the opposite. So when you have a stenosis of a sigmoid sinus, the transverse sinus will not collapse, it will enlarge, okay? So even if your stent is undersized, after you have resolved the stenosis, the sinus will shrink over your stent.
Yeah. In the vein, more long is the stent, more possibility you are the CP.
Probably, but the sinus is not a vein. The sinus is not a vein.
Dependent flow. When you are less flow, you are more device flow.
So the stenosis that are observed into the brain sinuses, they are not instant stenosis. They are not within the stent. They are end stent stenosis, or way above. They are not within the stent. It's not the same restenosis. No, we think restenosis, we think arteries, or we think veins. It's different into the sinus.
Another case, and this is my last question. When you are venous thrombosis, thrombophlebitis, and you are play, you are hemorrhagic venous contraction, you need to treat. It's possible to treat at the same time with the stenting. It's a balance the risk. No?
I think in the acute phase, so you can treat with the TTPA.
No.
And yes, aspiration, embolectomy, something like this. Yeah.
Pierre, again, on the trial, the true stenosis were outside of the stent.
Yes, they were above the stent. One was almost at the torcular, and one was at the superior third of the inferior sinus. So, but we think that it's because the stent was oversized, and this is because of a paper that Philippe Gaillou from Hopkins sent me. It's going to be published soon. And he described a rate of restenosis of 30% when he used large stent, 7 and 8 and 9, and of 10% when he used small 6 millimeter stent. So that's the reason also why we halted the enrollment into the trial.
Uh, 1:30. Okay.
So certainly,
10 minutes is possible?
well,
Yeah.
it's actually we don't know exactly. We know that it's not myointimal proliferation, etc. You know.
I continue the discussion in lunch.
Yes.
But I think there are many questions because in 20 minutes I'm going to lunch.
Yeah, yeah.
Fantastic.